So welcome back to this final session in our meeting. And we deliberately wanted to close with a session dedicated to young investigators because this entire endeavour is essentially about the future, and we're really keen to encourage young investigators, young clinicians, to become interested in this area and contribute to the development of the field. So with that, I'd like to hand over to my co-chairman to introduce the first of those speakers.
Hello, everybody. Thank you for the invitation. My name is Vasilis Vasilikos. I'm a professor of cardiology from the Aristotle University of Thessaloniki. And it's my pleasure to co-chair with Professor Perry Elliott this young investigator session. First of all, I would like to ask Dr. Douglas Cannie from UCL, London, who has done quite a lot of research in the mutations on RBM20, and he's going to give us a lecture about the natural history of dilated cardiomyopathies caused by the mutations on this gene. Dear Cannie, we're ready to hear you.
Great. Thank you for asking me to speak today. I'm going to talk to you about dilated cardiomyopathy and mutations in RBM20. And after a brief review of RBM20 itself, I'd like to introduce you to a cohort of patients we've collated with the help of our international collaborators. The RBM20 gene sits on chromosome 10 and is 14 exons long. And it's a modifier of post-transcriptional splicing of over 40 genes. And those genes include both sarcomeric genes, such as titin and LDB3, and also calcium handling genes, such as CAMK2D and RYR2. And the figure below shows the protein with the red bracketed regions highlighting those regions that are highly conserved amongst species. And I'd like to highlight in particular the RS-RSP stretch, which plays host to many of the mutations that we currently classify as likely pathogenic or pathogenic. So RBM20 was first linked to DCM in 2009 by a team in Rochester, Minnesota, and its prevalence in genotyped DCM cohorts is in the region of 2 to 6%, and it's around 2.5% in our cohort at Barts and UCL. And what do we know so far? So we know that it's associated with ventricular arrhythmia, with left ventricular systolic dysfunction and heart failure. And we often see family trees that are significant for young onset of the phenotype and sudden death, again, often at a young age. And we also see that male sex may be associated with a more severe phenotype. But there are still gaps in knowledge. We have limited genotype-phenotype correlation data and limited outcomes data in larger cohorts. We have a relatively poor understanding of the risk factors for both arrhythmic and heart failure outcomes. And there's no data really on whether specific RBM20 mutations are linked to different clinical phenotypes. And we sought to address this using our network of international collaborators. So we asked centres across the UK and Europe and as far as Australia, which you can see has helpfully drifted towards the east coast of Africa for the purposes of collaboration, for mutations in patients of a likely pathogenic or pathogenic as per ACMG criteria status. And we had 179 individuals provided to us across 12 centres. We've removed 9 of those with the reasons listed below, and we're left with 170 mutation carriers with baseline data or with characteristics sufficient for baseline data, and 163 for outcomes analysis with a mean follow-up of 7.8 years. And this next table illustrates our cohort in a bit more detail. So you can see that males and females are relatively equally split. Around a quarter of the cohort are probans, and just over 2/3 reached or met diagnostic criteria for DCM by the end of follow-up. We see that they do indeed get diagnosed with DCM at a young age, with a significant difference between males and females. males diagnosed at 32 years on average and 40 years for females. Interestingly, the vast majority are in sinus rhythm at baseline, and males have a longer QRS and poorer LV function at baseline. There's a relatively modest number of ventricular ectopics over 24 hours, and those that underwent cardiac MRI, around a third had late gadolinium enhancement. This is the same figure that I showed you earlier, but now annotated with mutations in our cohort. And in red are those we believe to be novel. And just to highlight that around 70% of our cohort are in the RS-RSP stretch that I mentioned earlier. So on to outcomes. And interestingly, very few had atrial fibrillation or flutter during follow-up. Around a third had an ICD implanted, and of those, a quarter had an appropriate shock. The only significant difference between males and females lies in the number of heart transplants, with 16 males, only 1 female undergoing a heart transplantation. And we wanted to explore the outcomes a little bit further, so we've created some composites. So we have arrhythmic outcomes, which include sustained VT or VF, ATP, an appropriate ICD shock, cardiac arrest or sudden cardiac death, and heart failure outcomes, which includes LVAD implantation, heart transplantation, or heart failure related death. And we've also got an overall composite outcome of both arrhythmic and heart failure events. And here are some Kaplan-Meier curves for you. So on the left, we have those arrhythmic endpoints. On the right, the heart failure endpoints, with males in blue and females in orange. And if we look at the arrhythmic endpoints first, we can see that around the 8 to 10 year mark, just under 20% of both males and females had experienced an arrhythmic event, with no significant difference statistically. In contrast, on the right, when we look at the heart failure endpoints, at the same time point, 8 to 10 years, just under a quarter of the males had experienced a heart failure event in comparison to very few females. This next slide, again, some Kaplan-Meier curves, and this is the overall composite. The only difference between the two Kaplan-Meier curves here is the x-axis. So on the left, we have during follow-up analysis, and while the males certainly visually appear to have more of the composite endpoint, that didn't reach statistical significance. And then on the right, we've shown the composite outcome, but with age in years on the x-axis. And this quite nicely visually shows that males are suffering these events at an earlier age. We wanted to explore whether any of the baseline variables that we'd collected influenced the outcomes, and just to highlight here that this is the arrhythmic outcomes we're considering here. On the left are the continuous variables, on the right the categorical variables, and you can see that both ECG and echo parameters feature, in addition to late gadolinium enhancement on MRI. Interestingly, this specific mutation at amino acid position 634 and heart failure symptoms. I've included sex there, but perhaps as we would have guessed from the earlier Kaplan-Meier curves, that did not reach statistical significance. By far the most influential and significant variable with regards to arrhythmic outcomes is baseline ejection fraction. And when we look at the multivariate analysis, when combined with ejection fraction, the majority of those variables lose significance. Two that don't are the mutation that I mentioned at position 634, in addition to late gadolinium enhancement, accepting that the confidence interval is relatively broad. And just to finish, an issue that we face in clinical practice is whether family members with a mild phenotype merit ICD implantation. Do they suffer arrhythmic events? And what we've done here is split family members by ejection fraction, so greater than 45% and less than 45%. And you can see that events in those with the milder phenotype were very rare indeed. So in conclusion, RBM20 mutations are associated with ventricular arrhythmia and heart failure, with, on our analysis, no significant difference between males and females in arrhythmic outcomes. Ejection fraction is the most important variable when considering arrhythmic risk, and we've seen that relatives with normal or near normal ejection fractions are relatively low risk, and specific RBM20 mutations may carry a higher degree of arrhythmic risk and certainly merits further investigation. So thank you very much, and these are both my colleagues at UCL who I'd like to thank, along with our collaborators internationally.
Thank you very much, Dr. Cannie. Very nice, very nicely shown clinical data. Just a question. Again, we see that males are suffering more than females once more. And your patients with the ICD implantation, how they were depicted? I mean, which kind of criteria did you use in order to implant an ICD on this?
Yeah, very good question. So from our own experience at Barts, these patients tend to go to an MDT where we discuss whether we feel they meet criteria for an ICD based upon, as you know, very limited data. From our international colleagues, I don't think I have those specific criteria as to what led them to implant the ICDs. My feeling would be that we've had a relatively low threshold to offer the protection of an ICD. And that was part of the reason why I showed that final slide, just to highlight that perhaps we don't need to move so quickly towards an ICD in those relatives who have the mild phenotype when you're looking at an ejection fraction of 50%. It did appear from our analysis that fibrosis on MRI may be significant. But I should also highlight that it did look as though they had a different ejection fraction at baseline.
And what about medication? For example, were they on verapamil or something that influences the handling of calcium in such patients?
So I haven't looked at that data yet. I do have the medication data to analyse. It looked around at baseline 40% of the total cohort were already on heart failure medications. But it's an interesting question. Do the RBM20 mutation carriers remodel? We'd love to answer that. Anecdotally, I'm not sure. It feels like some do, some don't. But when I think about the comparison to, say, desmoplakin mutations, it feels like they may remodel a little better than they do.
Okay, thank you. Thank you. Any questions, Perry? Yeah,
You're
muted.
It's been a long 3 days. It's your last question was a great one, because as you say, sort of mechanistically, one of the abnormalities that we think we see in RBM20 is abnormal calcium handling. But I suppose it runs counterintuitive when you're dealing with a patient who's got impaired left ventricular systolic function. So then give them a potentially negative inotropic drug like verapamil. But maybe that's wrong. Maybe we should have an earlier consideration for calcium antagonists.
Yeah. Okay. Okay. Thank you very much. Shall we move on?
Absolutely. So thank you for that, Doug. And we're now happy